Hello, everyone. Welcome to our Albinism Awareness Series, a joint effort between the ILDS, the GLODERM Trainee Committee, and the Global Albinism Alliance. My name is Akash Varma. I'm the current chair of the GLODERM Trainee Committee, and our co-host today is Antoine Glickson, the executive director of the Global Albinism Alliance.
Welcome, everyone. So we will have 4 different sessions in this webinar series. We will first cover genetics, then dermatology, then we will have a webinar on ophthalmology, and finally, a last webinar addressing the social impacts of albinism.
And all of these webinars will have additional live Q&A time. So as I mentioned, your hosts today are me, Akash Varma, and Antoine Glickson. So I just want to give you a little information about the organizations which we represent. GLODERM is the International Alliance for Global Health Dermatology, and it's an official program of the International Foundation for Dermatology under the International League of Dermatologic Societies. The mission for GLODERM is to improve skin health for everyone everywhere by connecting dermatologists and trainees who are dedicated to improving skin health for all in resource-limited communities locally and globally. I represent the GLODERM Trainee Committee, and our main mission is to make sure that we disseminate information to individuals all over the world and increase education for dermatologist training in all settings.
And as mentioned before, my name is Antoine Glickson. I'm the executive director of the Global Albinism Alliance. The Global Albinism Alliance is a young international NGO that was launched about 4 years ago in 2020. Today, we represent about 250 associations and other NGOs that are serving the albinism community in all regions of the world. The mission of the GA is structured around 3 main pillars. We exist first to support albinism organizations that operate around the world. We act also to improve knowledge about albinism. And finally, we are the voice of the albinism community at the global level. And in that frame, we advocate to improve and protect the rights of persons with albinism at that level.
Great. So just to run over some etiquette for today's webinar, if you have any questions or comments, please submit them via the chat function. Our speakers will answer your questions at the end of the webinar. And we will be sharing further information about the GLODERM Trainee Committee and the Global Albinism Alliance in the webinar chat, so please be on the lookout for that.
Before we start, I'd like to remind you that this webinar series is put together and offered to you as a way to celebrate International Albinism Awareness Day, which has been celebrated since 2015 every year on June 13th.
Welcome to our series today on dermatology. As we know, albinism causes hypopigmented skin, and this has a wide variety of impacts on our patients' skin health throughout their life. Today, we have 2 very exciting speakers here with us who will share their expertise, and we'll have some time at the end for a live Q&A session.
It is my great pleasure now to introduce to you Dr. Carolina Marçon, a dermatologist and professor at the Department of Dermatology at Santa Casa de Misericórdia de São Paulo in Brazil. With a PhD in health sciences and a deep commitment to social causes, Dr. Marçon coordinates the Pro-Albino Assistance Program for persons with albinism in São Paulo and the Nisi Watwa project in Angola, focusing on supporting vulnerable populations. Over to you, Dr. Marçon.
Good morning, everyone. At first, I would like to thank GLODERM, the International League of Dermatological Societies, and the Global Albinism Alliance for the invitation to participate in this event. And I congratulate all people with albinism and those who fight for this cause, for strength, achievements, and overcoming so many challenges. So let's go. As everyone knows, albinism is a rare genetic disorder characterized by the reduction or absence of melanin production. It can occur in a syndromic form, that is, with involvement of organs other than skin and eyes, the main syndromes being Irmansky-Pudilak and Sejaki-Higashi, or in the non-syndromic form, with involvement of the skin, hair, and eyes, or just the eyes. Melanin, the substance much talked about and known by people with albinism, is a pigment produced through enzymatic reactions and several steps by specialized cells called melanocytes. And melanocytes are present in the eyes, skin, and some other regions of the body, such as the meninges and the cochlea. In the skin, the function of melanin is to protect skin cells against DNA damage. And the sunnier a region is, the darker the skin of the original population. For example, in Africa, the population has black skin, and this is due to the wisdom of nature. It's nothing more than a survival mechanism against environment factors. There are different steps in melanin production, including processing, maturation, and transport. In albinism, we have several possible mutations which will interfere with different pathways of melanin production. And that is why we have so much variability in the presentation and color of the skin, making it impossible to distinguish the genetic type through clinical analysis. Here in these images, we can see the great variation we have in the skin and the hair color of children with albinism. Within the same family, there is, with the same mutation, we can have a significant difference in the color of hair, skin, and eyes, as is these three children here in this narrow, who are brothers and have different skin tones. Here are some more photos of people with albinism, showing the great variabilities of shades possible. And here are some men with shades ranging from white to dark brown. From a genetic point of view, when you consider the non-syndromic forms of oculocutaneous albinism, we have 8 possible affected genes identified today. The most commonly seen are those that cause oculocutaneous albinism type 1 to 4. The mutations responsible for albinism types 5, 6, 7, and 8 were more recently identified, starting in 2012. Type 8 was very recently discovered in France. Type 1 albinism divided into type 1A and 1B. Type 1A is the only one that we are able to identify at the clinic, as it involves a complete absence of pigment, with the hair and skin being completely white and the eyes being red because we visualize the retinal vessels through the transparent iris. All other types of albinism can produce varying degrees of pigment, and the identification through the clinic is not possible, only through genetic testing. Here we have a global overview of the affected genes and possible mutations. We can see that within the same genes, we can have several possible mutations. For example, in type 1, 303. Which explain the great clinical variability. Only type 80 was missing, which is new and not included in this table. The most predominant genetic types of albinism vary according to the geographic location, and on this map we can see a global panorama. Type 1 albinism is most prevalent in Europe and United States, while type 2 is the most prevalent in Africa. Although the real prevalence is completely unknown in many regions of the world, such as Brazil, where we don't know how many people with albinism there are, nor the predominant genetic type. And this is the reality in many underdeveloped countries. So these numbers are estimated and may be wrong. Regardless of the type of albinism, except for that which does not produce any pigment, type 1A, the little melanin that is produced is phenolmelanin, which is a type of melanin different from L-melanin, true melanin, which in addition to the mechanical barrier against radiation, has antioxidant action. Phenolalanin has a mechanical action in protecting the nucleus of skin cells, as we can see in these images, but it has a pro-oxidant action. This means that people with albinism, in addition to having a small amount of melanin, when they do have it, this melanin is generally phenolalanin, which oxidizes and promotes skin cancer. That's why people with albinism experience so much damage and tumors when they don't take care of their skin in relation to the sun. So, sun plus unprotected skin with albinism is synonymous of sunburn, premature aging, and skin cancer, which is the main cause of premature death in this population. Sun damage to skin with albinism is cumulative. Each small exposure causes a little damage, and this summation over time of small daily exposures will lead to skin cancer in the future. And this cancer can appear out of nowhere in the skin or from actinic keratosis, which are rough, red lesions common in the skin of people with albinism who are exposed to the sun without protection. And in other words, actinic keratosis are premalignant lesions which, when left untreated, can develop into skin cancer. And sun damage appears on the skin after about 15 years of sun exposure. And the main age range for damage accumulation is from 0 to 18 years old, which is why sun protection in childhood is so important. Here in these images, we can clearly see the difference between skin that was exposed to the sun with accumulated damage here, compared to unexposed skin, which was covered with clothing, showing that when the skin is protected against the sun, it will not present any problems. Burns like this one in this image, especially in childhood, are a major risk factor for the development of skin cancer in adulthood, which is why they should be avoided. Skin cancer appears in areas with the most accumulated sun damage over a lifetime, like here. And every small day-to-day exposures counts in the final sum. In the general fair skinned population, skin cancer tends to occur in older people over 60 years old of age. In sunny countries, 8% of skin carcinomas appear after the age of 55. For example, in a study from the Santa Casa de São Paulo Hospital, which evaluated people who had skin cancer for the first time, this occurred on average at the age of 68 years old. And in people with albinism, this occurs much earlier. In some African countries, it's common to see severe actinic damage and even skin cancer in very young children. And this comes from the intense sun exposure that these children have had since they were little. There is no access to health care or protective measures, so very young babies suffer serious burns due to the intense sun in the region. In these images, we can see the hands of people with albinism who live in Africa with very early age. Hands of very young people look like the hands of elderly people due to the large accumulation of sun damage. Here are some more images of children's hands showing how the sun can actually be harmful to the skin of a people with albinism who doesn't use sunscreen. Here in these images, we see the skin of a 28 years old woman who has worked on the farm since she was 4 and has never taken photoprotective measures, illustrating the importance of protecting skin with albinism from the sun from childhood. Skin cancer is the leading cause of death in people with albinism who live in sunny regions. As I said, it is quite common to see premalignant lesions in children, culminating in advanced cancer in the second or third decade of life. In some African countries, the life expectancy of a person with albinism is a maximum of 30 years due to skin cancer, which occurs aggressively and recurrently in this population. Here we can see some advanced tumors in people with albinism who have been exposed to the sun intensely through their lives. And I'm not going to go too deeply into this subject because the Dr. Daudi is going to talk specifically about this topic. Environment factors significantly influence the damage caused by the sun to the skin. So the reality is quite different, for example, in Europe and Brazil. In Europe and United States, the guidelines for sun protection don't even include ultraviolet index values above 11, as they do not occur. In Brazil, rates reach 14 even in winter, and outside of time is considered critical. The same happens in other countries with tropical and subtropical climates. Radiation about 8 is already considered critical for the skin, especially for skin without the natural protection provided by melanin. Here on this map, we can see the difference in the average ultraviolet index depending on the distance from the equator. For example, the incidence in equator is 200% higher than in Europe and the United States. And this explains the significant difference in the prevalence of skin cancer between groups of people with albinism in European countries and countries with hot climates. For example, in Brazil, a 26% prevalence of skin cancer was found in a group of people with albinism, compared to 0.5% in an Italian group. Thus, skin cancer may not be a problem in European countries, but in countries with a high level of radiation and little access to healthcare and resources, it's the main problem. Thus, regardless of the genetic type, even those that produce a significant amount of pigment, dermatological care is important due to the high risk of skin cancer. In countries with a high level of solar radiation, the use of photoprotective measures is essential to reduce morbid mortality and improve quality of life. Furthermore, dermatological follow-up is extremely important for early diagnosis and immediate treatment of skin cancer, which means healing without major sequelae. As I said previously, sun protection in people with albinism is important through their lives, but it's even more important until the age of 18, the main age for damage to occur, due to greater exposure at this stage. And regarding photoprotection recommendation, as we saw above, they should be more restrictive in sunnier countries due to higher levels of ultraviolet radiation. In these countries, it's essential to avoid direct exposure to the sun at any time of the day. Visits to the pool or beach should be restricted to the period before sunrise or closer to sunset, when solar radiation is lowest. If exposure to the sun is unavoidable, it is important to protect arms and legs with long sleeves clothing with specific fabrics containing sunscreen. And if this is not possible, opt for thicker fabrics such as jeans or fabrics such as polyamide and polyester, which were the fabrics used in football players' shirts, preferable in the colors blue, pink, red, which are the ones that block the most solar radiation. Hats, umbrellas, and glasses are also recommended whenever going out. In patients who already have significant actinic damage or have a history of skin cancer, vitamin B3, nicotinamide may be indicated, which plays several roles in preventing the appearance of new lesions. The hat is extremely important to prevent the accumulation of damage to the neck and ears. And it must be like this in this model called the Legionnaire, which covers these regions with a large accumulation of radiation on a daily basis. It's important that it has a flap of at least 8 centimeters, has no holes, and is made of thick fabric or with some protection. The common umbrella lets 6% of the radiation through. So it's important to use a specific umbrella, ideally with some protective fabric or double fabric, with a metal cover on the inside. These easily found umbrellas which have a silver interior. Sunscreen must be broad spectrum, that is, with protection against UVA and UVB radiation. And you should look on the label for the acronyms FPS, which must be greater than 50, and PPG, which must be greater than 20. These acronyms refer to protection against UVB and UVA radiation, respectively. It's also important that the sunscreen has approval from regulatory agencies, which are the FDA in the United States, EMA in Europe, and Anvisa in Brazil. This approval guarantees that the products have undergone tests that have proven their photoprotective effectiveness. The protector must be applied 15 to 20 minutes before going out and must be reapplied every 2 hours if the person remains exposed, regardless of the protection factor, because the sunscreen's photoprotective properties are lost over time. And there is no need to apply sunscreen indoors unless you are facing a window or in a partially covered area, so that the sun is hitting your skin. And the amount of sunscreen applied is also important, so that product guarantees the protection factor stated on the label. In the image, we have the teaspoon rule, which makes it easier to apply the indicated amount. The face, each arms, and each legs need a teaspoon each, and the torso, 2 spoons divided into front and back. We also have the 3 fingers rules for the face, in which we recommend amount for the face is estimated by completing these 3 fingers as in the photo. Periodic follow-up with dermatologists is essential for people with albinism. Monitoring from childhood allows the child to receive appropriate guidance in order to avoid any harm in adulthood. The dermatologist will also be able to diagnose skin cancer or precancer lesions early and immediately treat them, allowing for a cure, as well as treating spots and sun damage that can negatively contribute to self-esteem, as they interfere with aesthetics. Children should visit the dermatologist at least once a year, and adults at least twice a year, and at shorter intervals if there are significant changes in the skin. Here we can see 2 young patients with an aggressive type of skin cancer, melanoma, whose follow-up through dermoscopy allows the early diagnosis of the lesions and the cure of the disease. Here are some of the treatments we often perform: treatments of the field of cancers with a 5-finger seal, and down treatments of actinic keratosis and solar lentiginous with cryotherapy, allowing for improved aesthetics and quality of life. Regarding vitamin D and sun protection, there is a lot of incorrect information. There is an assumption that people with albinism, by taking extreme photo protection, would have low levels of vitamin D. and therefore would be at risk of developing various diseases. Therefore, many recommended vitamin D empirically for people with albinism, all people with albinism, or even sunbathing for children. Vitamin D is a fat-soluble vitamin obtained mainly from endogenous cutaneous production and to a lesser extent from the diet. And most of its serum concentration is due to the conversion of 7-daily cholesterol into vitamin D3 in the skin through UVB radiation. It, in fact, has a fundamental role in body metabolism, and more recent evidence shows that vitamin D is involved in numerous functions of the body, and this deficiency could be related to a multitude of diseases. The most robust scientific evidence shows that the use of sunscreen doesn't influence serum levels of vitamin D. Although laboratory studies reveal that sunscreens block the production of the vitamin, clinical studies carried out in real-life situations reveal that there is no reduction in vitamin levels. And the explanation for this is that a small amount of UVB radiation would be absorbed by the skin even with a high SPF sunscreen, especially in sunnier countries. Furthermore, study shows that the vast majority of people do not apply an adequate amount of sunscreen. We conducted a recent study at Santa Casa, which was my doctoral thesis, and it hasn't been published yet, in which we evaluated vitamin D levels in 42 people with albinism of both sexes, from children to the elderly. And the majority of them, 86%, used sunscreen and avoided directed exposure to the sun. The results revealed that 98% had normal vitamin D levels, 40% of which were above the upper normal value, and we even found an extremely high value, 85 nanogram per ml, in a patient who was taking restricted photoprotection. This shows us that vitamin D levels should not be a concern in people with albinism, especially those who live in sunny countries. Similarly, 3 other published studies that evaluated vitamin D levels in people with albinism in Africa compared to pigmented skin correlates revealed that vitamin D levels were higher in people with albinism compared to their counterparts pigmented, even with the adequate use of sunscreen. This shows us that people with albinism who live in regions with a high incidence of solar radiation are not a risk group for hypovitaminosis D, mainly due to the ease with which the skin, devoid of melanin, converts 7-GHC into previtamin D3. Light skin produces 6 more vitamin D than pigmented skin. Thus, normal values should be considered equivalent to those of the general population, and empirical supplementation is not indicated. In this population, highly susceptible to skin cancer, you should fear the harmful effects of the sun much more than hypovitaminosis D. Carcinomas increase morbidity and mortality and reduce quality of life, so that protective measures are mandatory and extremely important. And there is no indication of intentional exposure to the sun in order to produce vitamin D, especially for children. Vitamin D supplementation should be indicated based on individual needs, assessed through clinical investigation and periodic dosages. To conclude, we can note the significant influence of socioeconomic and environment factors on morbidity and mortality associated with albinism, making it extremely important to provide guidance, care, and access to health to these people. In countries with a high incidence of solar radiation, skin cancer is the main concern. Sun protection, skin care, and assistance programs are very important. the importance of regular consultation with a dermatologist for prevention, early diagnosis, and treatment of acrylic damage is also clear. Vitamin D should be indicated according to individual assessment, and guidelines regarding the sun, photoprotection, and periodic follow-up with a dermatologist can completely change the course of life of a person with albinism, showing the urgent need to develop public policies and assistance programs that can favor people with albinism, reducing the morbidity and mortality associated with the condition. Here are some photos of our group in Brazil and Africa, and for me it's clear that together we changed many things and we can still change much more. I thank everyone for your attention, and I wish you an excellent day of celebration and that everyone maintains the strength to change little by little all the negative issues around albinism. Thank you very much.
I'd now like to introduce Professor Daudi Mavura, an associate professor in dermatovenereology at Kilimanjaro Christian Medical University College and principal of the Regional Dermatology Training Center in Moshi, Tanzania. With extensive expertise in tropical dermatology and dermatosurgery, Professor Mavura is also a special advisor for the International Foundation of Dermatology Committee and a faculty member of the Dermatologic and Aesthetic Surgery International League. Over to you, Professor Mavura.
Hi everyone, my name is Professor Daudi Rajabu Mavura. I am Associate Professor of the Kilimanjaro Christian Medical University College, and I'm also a head and principal of the Regional Dermatology Training Center in Moshi, Tanzania. Today I'm going to talk about tropical dermatology from people living with albinism perspectives. Skin disease is estimated to affect more than 900 million persons globally each year. 20 to 40% of new consultations in tropic climates at primary care level are motivated by skin problems. Tropical dermatoses are divided in several groups. Here we will discuss about bacterial skin infection such as pyoderma and cellulitis, mycosis including dermatophytes, as well as candida and molasses infection. Viral skin infection like warts, herpes simplex, and molluscum contagiosa. Infestations like scabies are variable and changeable over time. What is the significance of that? A recent WHO program have been to take advantage of the fact that many of these serious diseases seen in the tropics, such as leprosy and river blindness, first appear in the skin, and that by detecting them because of their appearance in the skin, their treatment and control become much more visible. While the pattern of skin diseases is dominated by infection in tropical country, it is important to recognize that other skin diseases may have an important impact on health. Atopic eczema is now seen more frequently in clinical services, and there is evidence that the prevalence of atopic eczema is increasing in some tropic areas. For instance, in oculocutaneous albinism, with its attendant risk of early non-melanoma skin cancer, is more common in tropic region than the colder north, affecting those living in countries from Central America to Sub-Saharan Africa and the Pacific region. This poses a strain on resource-limited health system. If it is ignored and patient left without sun protection, advance as well as treatment. There is a high risk of fatal squamous cell carcinoma. Certainly, population are also susceptible to other specific skin conditions. Climate changes and tropical dermatology. The way in which our planet's climate is changing will influence the distribution and frequency of dermatologic conditions, particularly those associated with infectious etiology such as sun exposure, environmental irritation, and aquatic transmission. Changing environment conditions also influence the behavior and habitat of disease vectors, resulting in newly broadened regions of endemicity. Inflammatory dermatoses are sensitive to changing environment conditions. Air pollutants such as small particulates matter may exacerbate chronic conditions such as pemphigus and atopic dermatitis. Warming bodies of water and precipitations shift due to climate change also pose an exposure risk for aquatic transmission dermatologic condition. UV damage in the tropics. Global populations are at a universal increased risk of skin cancer due to the Earth's diminished atmospheric ozone layer, which is a result of the anthropogenic activity leading to climate change. We are doubly exposed to the elevated ultraviolet radiation, both from depleted protective ozone layer and from higher temperature, which leads to increased UV damage at the same dose. Warming climates in temperate zones also encourage more outdoors activity in the general population, compounding the extra UV exposure. Not only does this contribute to melanoma and non-skin melanoma incidence, UV radiation, temperature, and air pollution are also associated with exacerbation of the other skin diseases. Now let's talk a little bit about albinism in Tanzania, Taradc. You can see that photo is a photo of people we attending in our satellite clinics where we see them every 6 months and we provide them with all treatment for people living with albinism, including counseling until excision of pre-malignant and already settled malignant, if any. The term albinism is derived from alba, which means white. It applies to a group of inherited disorders that are characterized by decreased or absence of melanin pigment in tissues, together with developmental abnormalities of the eye and visual pathway. The skin and hair color of patients with albinism depend at least in part on the amount of melanin pigment present and the underlying metabolic defect. Pigmentations can be completely absent throughout the lifetime of the individual or may increase to nearly normal level in the first few years of life. Now we'll talk a little bit about epidemiology of albinism. Albinism has been seen worldwide. It tends to affect people of all ethnic backgrounds. Both male and female can be affected. However, in OCA A1, X-linked recessive, which means is ocular albinism, males are affected while female are only carrier. Frequency worldwide is 1 in 17,000 to 20,000 in most population. Sub-Saharan Africa, the incidence range from 1 in 5,000 to 1,500 people. This is according to WHO. In Tanzania, 1 in 1,429 births to 2,500 people. So this is really alarming. The mortality and morbidity of people living with albinism. Albinism is not associated with mortality. Lifespan is within normal limits. The reduction of melanin in the hair, skin, and eye should have no systemic effect. The general health of a child and an adult with albinism is normal. The growth and intellectual development of a child with albinism should be normal, with developmental milestone expected for age, meaning they have the same IQ as we have. The morbidity associated with albinism pertain to visual impairment, skin photosensitivity, and increased cutaneous cancer risk. Patients who have syndromes associated with albinism may have hearing difficulties or abnormality of blood clotting. Albinism also has social ramification because patients may feel alienated as a result of the differences in appearance from their families, peers, and other members of the ethnic group. What are the risk factors? Children of parents who both have albinism. Children of parents who do not have albinism but both carry the albinism gene. Positive family history for albinism, sibling or relatives. Males as a link, as X-links ocular albinism exclusively affects male. Being of Sub-Saharan Africa or Puerto Rico heritage, albinism. What are the risk factors? Children of parents who both have albinism, children of parents who do not have albinism but both carry the albinism gene, positive family history for albinism, that means sibling or relatives. Male as X-linked ocular albinism exclusively affect males. Being of Sub-Saharan Africa or Puerto Rico heritage. What are the complications of people living with albinism? There are several complications ranging from eye, skin cancer in people with albinism, other actinic damage. In eyes, we can see photophobia, decreased visual acuity, extreme sun sensitivity. In skin, we can see different type of skin ranging from squamous cell carcinoma, BCC, up to amelanotic melanoma. We can also have pre-malignant lesions such as actinic keratosis, actinic cheilitis, solar elastosis, and keratoacanthoma. Now let's look a little bit about skin cancer in people living with albinism in the tropics. So several studies have been done at RDTC. One of them was histological review of skin cancer in Africa albinism. This was a retrospective study which was conducted for 10 years. Another study which was also done was skin cancers among albinism at the University Teaching Hospital in northern Tanzania. This was a retrospective review of 64 cases. Another study which was also done here at RDC was to look on the patterns of skin cancer and the treatment outcome for patients with albinism at our center. All of these studies come with conclusion that squamous cell carcinoma is the most common cancer seen among people with albinism in sub-Saharan Africa, which are well differentiated type in the most common subtype. Basal cell carcinoma account for approximately 40% of NMCC seen in the tropics. Acrolentiginous melanomas, rarely seen, however, can still occur. So these are some of examples of the patient we usually encounter. As you can see, we have a variety of range of cases. We are seeing from mild cases with cases which can easily be managed and cases which are really advanced, and what we can do is only palliative. But it is important that those students who have seen some publications which have been done to start early the albino outreach clinic so that they can be seen regularly to prevent this advancement of tumor which eventually become inoperable. And as you know, most of these people are coming from interior, so if you ask them to go for chemotherapy, if it is squamous cell carcinoma in Dar, where we have our oncology hospital, they usually don't want to go. So again, the primary care is mandatory for those dealing with people living with albinism, especially our community dermatologist. So this is one of the examples whereby, as I said, patients come from very interior areas and whereby such early BCC, which is very slow progressing, can be seen as a wound which is infected. But when it came, we managed to realize that this is BCC, and the first thing we had to do is to treat the infection, and now we will go into excising the tumor. So now we come to the treatment of people with albinism with their skin cancers. They can present with actinic keratosis. The management can be lesion, field directed, or both combined. Lesion directed treatment is the first line approach for isolated lesion. That is imiquimod 5%. We can do photodynamic therapy, we can do curettage, or we can do cryotherapy. Field directed approach is used when multiple lesions are present. Therefore, we have now in a process of starting the study on testing the nicotinamide, if this can as well prevent skin tumor in people living with albinism, as the publication shows. So we continue with treatment in skin cancer. So depending on the type of lesion and size of the lesion, we can always decide to either use cryotherapy and destroy it completely. If it's too small, you can as well use topical chemotherapy, since when you have multiple small pre-malignant lesions which can develop to skin cancer, you cannot cryo it, you cannot do surgery completely. But some, they need to be excised depending on the histology, which shows they are so deep, so we cannot apply it there. And those who are presented with very advanced tumor or very deep, where we cannot operate, then we send them for radiotherapy in Ocean Road, provided that the histology is telling us that this is squamous cell carcinoma. As we have heard from the ophthalmologist who are specialists in this, one of the major complications of these people living with albinism is eye problems, which are several. So kindly remember to refer them to ophthalmology so that they get special refractory, as this problem of people with albinism, they need special trained ophthalmologists. As what you have seen here in RDC in our albino outreach program, when we have these people, we work with Standing Voice who have trained specific people to deal with eye problems. So finally, how can we prevent the complication of people living with albinism in all these tumors which are happening to them, with all the complication of eyes? The main thing is avoiding of exposure to UV light, and this can be achieved by using high sun protective factor, by using protective gears such as brim hat, scarf, long sleeve shirt, long trousers and shirt and skin, as well as shoes, because most of them, they usually don't wear shoes, and this is important, as well as sunglasses. Regular scanning for skin cancer is mandatory, because if we can manage to catch up the pre-malignant lesion, we should be able to use simple measure to treat them, such as cryotherapy, as we discussed before. Genetic counseling is one of the issues that we have really to introduce it in our albino outreach programs, because it's very difficult to tell who is carrying the gene or not. When we are treating people living with albinism, you have to consider several things. One, the management of patients with oculocutaneous albinism involves strict sun protection, which begin from infant, and treatment of high refractive error with glasses or contact lenses. Support group and information sources are available worldwide. Individuals with albinism are preferentially referred to us as people with albinism instead of albinos. So what are the challenges people with albinism face? One, inhibition of daily activity due to complication. Due to lack of vision they have, they're limited to do works which they need their eyes to work on. So they cannot, simple things which they're supposed to do indoors, they cannot do them, such as sewing. They need the eyes. So for them it's very difficult with the vision. So they have to work in a limited hour. For example, if they have to go to shamba cultivating, they have to go early in the morning and stop around 10. Then they have to go late in the evening, which is for them also very difficult. Stigma from the society. Stigma from the society. Many people, they don't know this disease. Example, the Maasai, whereby we observe that long term there were no any child who was born with albinism in the Maasai society. This is because that they had bad belief on people with albinism, that if you keep that child, you are bringing a problem in your society, and they used to kill them. Culture belief. We have a lot of wrong culture belief, especially the business people, who believe that if they kill an albino, they get one of their part of the body, they will get rich. Or politician, when they go for election, they think, they are told by this witchcraft that if you get a hand or any part of albino, you will win the election. limited knowledge about the condition. Also, this is a major problem that family and school they don't understand, and this we have observed it in our albino outreach program, whereby we go to the school. When we talk to the teacher, we inform them about this student are normal as other student, they have normal IQ, given chance they can perform. So they have to sit in front, they have to be given special assignment during when sun is not at top, so that they can live and perform as others. Lack of employment, it's also a major thing for them because most of them. So again, these are my references. Thank you. So thank you very much for listening, and I'll be online in case of any further clarification on my presentation. So thank you very much.
Hello, everyone. As we are now in our Q&A session, please submit any questions you may have in the webinar chat, and all speakers will answer them shortly.
Thank you all so much for joining us in today's talk. It's been such an insightful, such educative and great and fantastic learning experience. Thank you so much, Dr. Carolina, and thank you so much, Professor Daudi Mavura, for your lectures. So I'll take this opportunity to hand over to Dr. Stembiso to continue with the question and answer section. Thank you.
Prof. Carolina, as well as Prof. Mavura for such insightful lectures. So there are a couple of questions here. The first one that has been raised was, what advice do we give a mother with a newborn baby with albinism? So it's directed to, Prof. Caroline.
I thank you for the opportunity to stay here, and it's a pleasure to share and to stay with you. I think the most important is these children are well oriented by dermatologists and by ophthalmologists, and take care of the sun, see the skin periodically, and take care of the sun since baby, because the most important age to establish the damage in the skin is just in childhood, from 0 to 18 years. So it's very important for these children to be oriented, well oriented, to use the sunscreen and see periodically by dermatologists and also ophthalmologists.
Thank you for that. And the second question is, what is your experience with regards to access to sunscreens? Both you are from Brazil and Prof. Mavura is from Tanzania. How has your access to sunscreens been?
Here in Brazil is not so easy. The access is not so easy for people that don't have money to buy. We are trying to talk to government. We have laws and permits, but anyone is approved yet to provide the sunscreen in the public organs, but not yet. And some patients do a kind of process in local government to ask to sunscreen, and they succeed, but not all of them. So in Brazil, we have access, I think, better than many countries in Africa, but not like Europe. It's limited access, not for all. I don't know if it's that was asked. It's okay,
Yeah.
my answer. Yeah.
Yes. No, thank you so much. That's clear. Prof. Mavura, on your side
Yeah,
in Tanzania.
yes. Yeah, thank you very much for your question. I think it's still a problem that, for example, in Tanzania, we have a very large population of people living with albinism. And to have a proper sunscreen is still a problem because most of the people with albinism are poor. We are purely depending on support. So, yes, it will be nice that we are working with Minister of Health that now sunscreen it's already entered in the essential drug list. So medical store department, they will be forced to buy it from Tanzania at Regional Dermatology Training Center, where we are now producing a sunscreen.
Thank you. Are you done, Prof. Mavura?
Yeah, yes, sure.
Yes. All right. Yes. Just as a follow-up question, the difficulty in accessing sunscreens. Do you think that with advocacy, can we push for WHO to make it a human rights issue? Because if one person doesn't have sunscreen, then more likely they are to develop cancers, and some cancers become big, such that actually people with albinism actually die from these cancers. What is your take? Yeah.
Uh, yeah, currently WHO through IFD, we have several committee. I am a member of one of the committee which we are now working on making sure that these drugs like sunscreen are entered in the essential drug list and country will be forced to buy them. However, I will say that sunscreen is not everything because we have seen a lot of people who are coming, especially today. I'm currently in Dar es Salaam in Bagamoyo where we are celebrating the International Albino Awareness Day. And unfortunately, I met some Koreans who are just dishing some sunscreen.
Um,
In education and think screen hand to with clinical examination treating people. I will get
okay. I think we seem to be losing Prof. Mavura there. Yeah, maybe we'll come back and finish up. Can you hear me?
Yeah.
Yes. All right. No. Thank you so much. Yes. Do you mind maybe finishing off that question, Prof. Carolina?
Yeah, I don't know if I completely understand, but I completely agree with some things that Dr. Mavura said. I think sunscreens is not the all. There are uh, other things that we have to orient and the people with albinism have to do to protect the skin. And when a sunscreen is not available, we have other measures that can be adopted to protect the skin and to prevent skin cancer. And I think putting clothes that cover the body is one of the most important things. and avoid the directed exposure to the sun, because even with sunscreen in some countries, like countries there is near the equator, the incidence of radiation is so high, and even with sunscreen, there is the possibility of damage the skin. And I think it's important in these countries to avoid the direct exposure to the sun, to put clothes that cover the body, the most part of the body, and put hats and glasses, and at the end, the sunscreen. And I think this orientation seems the, the, the beginning of the life is completely changed the course of life with a person with albinism. And when it's impossible this access to sunscreen, we have to do these measures, and it's effective also. It's my impression.
All right. No, thank you so much. Thank you so much, Dr. Carolina, for that. Yeah, we have Prof. Mavura is back. I just wanted to go to the third question, which it says, no, there are different types of sunscreens in the market. There's chemical, there's physical, there's hybrid. Are there specific sunscreens that are meant for people with albinism?
My knowledge, we don't have something that is specific. I think what's important in sunscreen is that the sunscreen is tested before is approved by the FDA and EMA and this in Brazil. I don't know what's the regulation in countries of Africa, but it's important that the sunscreen is approved and is tested, because it is guaranteed that the product is going to protect against the skin. And I think it's important to have a high FPS, that is the protection against the UVB, and high PPD, that is the nomenclature that guarantees the protection against UVA. And if it is physical or chemical, it doesn't matter, unless in children. That in children, the physical sunscreens is more recommended, because the children have a fine skin, thick skin, fine skin, and the absorption is high. So it's important that sunscreen have large molecules, not to penetrate the skin. So I think if it's physical, chemical, the importance is that this sunscreen was tested by the specific test that we recommended, and have the FPS more than 50 and PPD more than 20. And this is, and it's important to reapply, because after a period of time in the sun, the sunscreen, the physical characteristics and chemical characteristics of sunscreen change. So it's important to put the sunscreen and in an adequate quantity, and reapply if there is exposure to the sun every 2 hours. This is very important.
Thank you so much. Yes, Prof. Mavura, you wanted to say something?
Yeah, sure. I would say that, yeah, it is important that people with albinism get specific sunscreen for them. Yeah, because if you look at already ready-made sunscreen, they have they have a lot of ingredient which they might cause some reagent, like perfumes and colors, which are not really very good. People with albinism, they need sunscreen which is a little bit thick, which will stay for longer time in their skin. And currently, we have sunscreen which has chemical filter and also physical filter, whereby the chemical filter will absorb the UV direct, and the physical filter will make a screen whereby will protect it from running on it. And we also make sure that it contains titanium dioxide and zinc, which also have they soothe the skin, and they also have inflammatory activity. So I think it's important that we make sunscreen which is specific for them. That would be my.
No, thank you so much for that. The fifth question is on the 25th, if I'm not mistaken, of June, it's World Vitiligo Day. And both these patients have decreased melanin. But what we tend to see is that most of the patients with vitiligo on that affected area, they tend not to develop cancers compared to patients who are living with albinism. Do you mind explaining, what, the difference between the two so that you can be able to understand? Yeah. Yeah. This one is also directed either maybe Prof. Carolina or Prof. Mark.
Okay, I answer. One of the explanations for that is that is because we have two types of melanin, the L-melanin and phenolmelanin. L-melanin is the one that is considered the real melanin, that is the one that is brown to black, and have characteristics to protect physical protection of the skin because the pigment is produced and stay above the nucleus of the cell. And this kind of melanin have an antioxidant action also, is the physical protection and antioxidant action. And we have another kind of melanin that is phenolmelanin, that is the one that is more yellow, orange. And this melanin do this kind of protection, the physical protection, but have a pro-oxidant action. So this melanin favor the appearance of cancer. In vitiligo, we don't have any kind of melanin, is without any melanin. In albinism, the most part of the patients, only the type 1A that don't have any melanin. The other types have a little of melanin, and this melanin is phenolmelanin. So people with albinism have a little of melanin, but this one is pro-oxidant. Because of that, they have more possibility of cancer. And in vitiligo, we don't have any melanin. For example, the type 1A of albinism has less possibility of cancer than the other types because of that, because the melanin is absent. And in other types, we have melanin, but in low quantity. And this type of melanin is phenolmelanin. There is pro-oxidant that favor the inflammation, favor the cascade that conduct to the cancer. Do you understand? Yeah.
Yes, no, I do.
The explanations.
Yeah. So the difference is between the melanin, the type of melanin that is produced, eumelanin and pheomelanin.
Yeah, phenolmelanin is produced in albinism in the most part of the types, and is not produced in vitiligo, is pro-oxidant, favor the appearance of cancer.
Okay. Thank you so much. And the sixth question is the drug nitisinone increases melanin production. What are the limitations of nitisinone injections for persons with albinism?
What's the drug?
It's nitisinone. Nitisinone, yes.
It acts. I'm not completely informed about the studies of these drugs, but it's acted only when we have a specific via of production of melanin. So people with albinism that don't produce any melanin don't have any kind of benefit with this drug. I don't know if Dr. Mavura know more about this drug. And Nichigazona, is that? Nichigazona.
I'm not sure. I'm not very familiar with it.
Okay. All right. All right. No, thank you. I think it will be homework for us to go and check what this drug does and if it can be able to be of use to people with living with albinism. Of course, I can imagine that the cost also is very high. So yeah, we are struggling to just get sunscreen. And so what more of these big drugs and much expensive drugs such as this? Yeah. All right, there is a question.
Yes, and I think it's only for what I know. I think there are people that know more about that, doctors that know more about that. I think it's not studied, it's only in animal phase. I don't know if it's just in humans. I'm not sure about that. I think we have to study more to talk with more prophets about the new studies about this drug.
Thank you so much. Yeah, all these drugs, they start from animals mostly. Then, if it passes, different stages, then it gets to be tested on humans. Yeah. The eighth question: do you find a high incidence of skin cancers in those with ocular cutaneous albinism too, without lentiges, than in those who do have lentiges?
I think we don't. There is a I don't know. There is. I don't know how can I say in English. Is there? We suppose that people with albinism and lentiginous has less possibility of skin cancer because of the protection that this pigment provide to the skin. And there is types of in Africa. I saw this time people that live that in specific communities that has a lot of lentiginous and the skin stay like all black because lentiginous is like aggravated, and this is a skin like a black skin with high protection above the sun. But the one that have not so much lentiginous, we don't have a specific study that compare the incidence of skin cancer between these people and the one that don't have any lentiginous. And I think lentiginous like actinic keratosis, like skin cancer, like elastosis is a signal of damage to the skin. Lentiginous is a reaction from the incidence of the skin, the sun in the skin. So we consider a kind of actinic damage. So people with a lot of lentiginous, I'm not talking about this one that I told you that stay all black. The one that's have lentiginous is the one that have a high incidence of sun in the skin because it's also a kind of actinic damage. You understand me? So I think we have to study this specific issue to know more about that. But I'm not sure that people with lentiginous have less possibility of skin cancer because it's also actinic damage. I don't know if I make myself clear to understand. What is that?
No, that is
Understand?
clear.
Yeah.
No, it's clear. It's clear. Thank you so
Yeah,
much.
yeah.
Yes. Prof. Mavura?
Yes, I think it's an interesting observation which we have seen it in our albino outreach program, which have been running for the past 30 years. It's true that those people with albinism with lentiginous, a majority of them, they don't present with skin cancer early. And this is something we are now studying, and we should be able to give a clear result, a clear description why they don't. We hypothesize that they might have more protection, but we want to see in the cell in a melanosoma, is there a lot of melanin really, or what is it exactly? So it's difficult to clearly say, but we think they have more protection than the others.
Okay. All right. No, thank you. Not sure that we have just two more questions to go. The one will be Prof. Mavura can answer it. It says, what advice would you give to a healthcare worker upon presenting with a suspicious lesion on the way forward? How to manage? I guess this is a more management question.
Yeah, sure. So, first of all, it depends what a person with albinism can have a trauma, a normal trauma, and a wound, which does not necessarily being a skin cancer. But what I will say is you must take a clear history on how long, because if he has started with a lesion, maybe a tiny papule or a bump for more than 6 weeks, 1 year, then we will think maybe this is BCC, which will be maybe slight transparent bump which has been there. But if it comes with a lesion which is growing very fast with ulceration, with very sharp margin, then we say maybe probably is a squamous cell carcinoma. But all of that will depend on the physical examination history and the biopsy. Usually we have to take a biopsy, whether punch biopsy or excisional biopsy, removing it completely, then analyzing it, closing it, and get the biopsy result, whether it's free, what type of tumor was, and accordingly, then we can continue. That will be my advice.
All right. Thank you. Thank you. Thank you so much. The last question, probably Cindy can be able to answer this one. It says, has GLODERM contacted large pharmaceutical companies to be able to provide sunscreens? I think I can just summarize as that. Has GLODERM contacted large companies in order to provide sunscreens, pharmaceutical companies? Yeah.
I think you've decided to put me on the spot today. But I cannot speak on behalf of GLODERM right now in detail with the answers in terms of partnering with companies or things like that. But I'd say with the aim of GLODERM being skin health for all and ensuring the skin health equity, definitely there's some talks we can try to do. But for now, I cannot give you a concrete answer to that question. But lobbying is definitely part of GLODERM's mandate.
Yes. All right. Thank you. Thank you so much. Sorry for putting you on the spot right there. Yeah. Now, we've come to the end of our session. Our questions have all been answered. Thanks a lot, Prof. Carolina. Thanks a lot, Prof. Mavura. I'll hand over to Cindy. Yeah. Yes. To official.
Right. Thank you. Thank you, Dr. Tembeso, for guiding us through the Q&A. Thank you, Professor Daudi and Professor Carolina, for the fantastic talks and for engaging us in the Q&A section. And I'm sure we've all learned a great deal. And I mean, we've expanded our knowledge in the field of albinism. We are definitely going to practice what we've learned today and share this knowledge with others. Over to you, Akash, for the closing remarks. Thank you.
Thank you very much. Thank you. It's a pleasure.
On behalf of GLODERM and the Global Albinism Alliance, we'd like to thank you for participating in our webinar, and we encourage you to go to our social media platforms to learn more about upcoming events, webinars, programs, and more. Anything to add, Antoine?
Well, thank you again for joining us today. We very much hope that you've extended your knowledge about albinism through this webinar session. And we very much hope that you will now share the information and at your turn raise awareness about albinism among your colleagues and in your location. Thank you very much.
And finally, I'd just like to thank our sponsors, CeraVe, Ellis Foundation, and the International Society of Dermatology. Thank you all and have a great rest of your week.
Thank you. Goodbye.